Welcome to this explainer on the concept of difficult-to-treat depression and selected practical management strategies designed specifically for postgraduate psychiatry residents. Let us begin by discussing the paradigm shift in how we conceptualize this condition. The old model relied on the term treatment-resistant depression, which is a strict consensus definition applying to patients who have not responded to at least 2 standard therapies in their current episode. This term was borrowed from medical microbiology, but a human being failing to respond to an antidepressant is far more complex than a bacterium developing antibiotic resistance, making the term quite unsatisfactory. The new focus is difficult-to-treat depression. This broadens our perspective beyond strict definitions and prompts the clinician to consider the whole person. Non-response is just one way to describe these patients. Some patients are unlikely to improve even without prior treatment failures due to factors like childhood trauma, substance dependence, or comorbid anxiety. When initiating treatment, don't just blindly choose a SSRI or SNRI. Rather, match the agent to the patient for first-line selection. Example, if avoiding sexual side effects is a primary concern, bupropion is your first choice, whereas SSRIs and SNRIs should generally be avoided. If a patient presents with insomnia or sleep problems, mirtazapine is an excellent option as it stimulates appetite and promotes sleep. Conversely, if the patient struggles with low energy and motivation, bupropion is preferred for its non-sedative, energy-enhancing effects. You should always avoid prescribing a sedating medication if the patient has no sleep difficulties. After the first medication trial, you will face the decision to either switch or augment. If the patient experiences intolerable side effects, dose-limiting side effects, or obtains no benefit while suffering from bothersome side effects, you should switch. You might consider switching outside the original class, such as moving to bupropion or mirtazapine, especially if symptoms worsened. However, if the first medication was somewhat helpful and produced no significant side effect problems, it can serve as a stable platform. In this scenario, you should augment by adding a second agent to improve the response. When augmenting, always target specific residual symptom clusters. For residual anxiety, consider an anxiolytic like buspirone. Buspirone is less expensive and generally better tolerated, though it is probably less well-proven than newer agents and does not work well for intense panic. For residual insomnia, a sedative hypnotic is appropriate. When looking at atypical antipsychotic augmentation, remember that there are large differences in tolerability regarding weight gain, metabolic issues, and insomnia. In terms of overall effectiveness, lumateperone demonstrates better effectiveness, whereas quetiapine demonstrates less. Among the D2 partial agonists, aripiprazole is a cost-effective generic option. Brexpiprazole is branded and was synthesized to address some of aripiprazole's shortfalls, making it better for anxiety and sleep with a lower risk of akathisia. Cariprazine offers a more dissimilar mechanism if you need to avoid weight gain or excessive sedation entirely. Finally, consider pramipexole and dopamine agonists for a niche role in patients experiencing difficult-to-treat depression with severe anergia. Studies show significant antidepressant effects at higher, tolerable doses. This is an off-label use, typically starting at 0.5 milligrams 2 to 3 times a day. Be aware of the safety concerns regarding new-onset compulsive behaviors like gambling, hypersexuality, or binge eating, which necessitate explicit informed consent. Psychostimulants can also be a practical augmentation strategy when there is comorbid ADHD or a need to quickly improve functional status, focus, and adherence without worsening the underlying depression.